Assalamu alaikum everyone, good afternoon. Hope you guys are doing well. And our topic for today is treatment of hepatitis B and C. So we should start as we are already lagging behind as usual. So treatment of hepatitis B and C. First of all, should have a double-stranded DNA virus and belongs to the hepatinovirus family, incubation, and there's horizontal transmission via intercourse, percutaneous inoculation, nosocomial infection, transfusion, and transplants. And pathogenesis हम लोगों को पता है, it incorporates into the host DNA and integrates into the host hepatocyte DNA, implicated in the development of hepatocellular carcinoma. Hepatocyte DNA में भी incorporate करता है ये, और host DNA जो होता है उसमें भी incorporate करता है for the formation of new virions. Symptoms हम लोगों को बहुत पता है, initially hepatitis B के जो symptoms होते हैं, they're like very vague. जो initial infection होता है, जब person initially infected होता है तो उसका बहुत vague symptoms आते हैं, flu-like symptoms होते हैं, and then usually asymptomatic भी होता है. Then increasing severity जैसे जैसे होती आती है, you move on to the symptoms such as spider angioma, ascites, ecchymosis, caput medusa, jaundice, hepatic incaf, decompensated liver disease के साथ signs है. Extrahepatic manifestations भी हम लोगों को पता है. Basically, this is an overview. I'm sure you guys know all of this. Just for the sake of it, इसको include किया गया है. Diagnosis and treatment में, you know, diagnosis is by the surface antigen, which is hepatitis B surface antigen, and antibody against this antigen indicates either seroconversion or immunization. Then you have the hepatitis B E antigen, which denotes active viral application or infectivity. And core antigen, what does it denote? It indicates prior infection. So moving on to the treatment of to undetectable levels, seroconversion of hepatitis B at E antigen from positive to negative. Transferase. These hepatitis B E antigen, and you are able to reduce the levels of serum aminotransferase. Basically, it's going to do an improvement in the necro-inflammatory disease which is caused by hepatitis B virus. And it also leads to decreased risk of hepatocellular carcinoma and cirrhosis. Basically, आप अगर इन सारी चीज़ों को करते हो तो ये सारे जो end जो वो हैं disasters वो आप prevent कर सकते हो. Cure is basically there in contrast to hepatitis C treatment. Why? Because it incorporates into the host DNA. So moving on to the drugs. Basically, we have 8 drugs that were approved for the treatment of chronic HBV infection in the United States. You have oral and injectables. Injectables में आपके पास interferons आते हैं, and oral में you have drugs which are also used in HIV therapy. Lamivudine हो गई, Edufovir, Depovoxil, Tenofovir, Disoproxil, Tenofovir, Alafenamide, and Elbivudine. इनके नाम बहुत weird नाम है, बहुत weird names हैं, इनको याद करना बहुत ज़्यादा मुश्किल है, but we have to do it for the sake of it. First, we'll talk about interferons. Okay, interferon injectables की हम बात कर लेते हैं. Interferon alpha 2B and pegylated interferon alpha 2A. So basically, what are interferons? They are basically host cytokines that exert complex antiviral, immunomodulatory, and anti-proliferative actions. What it does is it inhibits the penetration of virus, its translation, transcription, protein processing, maturation, and release. So by doing this, inhibition of all of this, it's basically doing an antiviral activity. ये खुद जना antiviral नहीं होते, इनकी activity जो actions इनके होते हैं, they cause the virus to die. It is also immunomodulatory. How? It increases the host expression of MHC antigens. So what it does is MHC होता है तो आपको क्या पता है MHC class 1 class 2 से आके फिर जो है ना CD4 cells bind करते हैं और उसी से जो है ना फिर आपका immune system आगे
अभी तक शायद शो नहीं हुई स्क्रीन आपकी.
एक सेकंड मुझे देना. It's really sorry, voltage issues और जो है इस वजह से router मेरा बहुत ज़्यादा fluctuate कर रहा था तो I had to convert the electricity on generator. Sorry about that. Can you guys hear me now properly? Sorry for the delay. Interferons basically हम बात कर रहे थे. Interferons की हमने बात की कि they are antiviral, they are immunomodulatory and anti-proliferative actions. Interferon alpha 2B is licensed for the treatment of hepatitis B, whereas 2A, alpha 2B, and alpha con 1 are licensed for the treatment of Hep C infection. It can be administered either subcutaneously or intramuscularly. Half-life is 2 to 5 hours, depending on the route of administration. So, what's pegylated interferon? Pegylated interferon क्या है? Peg means polyethylene glycol attachment. So basically, when you attach a polyethylene glycol molecule to a protein, what it does is it becomes pegylated. इससे होगा क्या कि it reduces the rate of absorption following subcutaneous injection. It reduces the renal and cellular clearance and also decreases the immunogenicity of the protein. Basically, ये सारी चीजें क्या करेंगी? This will increase the life of interferon in the body and it will lead to steadier plasma concentrations. Renal elimination of pegylated interferon alpha 2A and 2B accounts for about 30% of the clearance. Again, 2A is licensed to treat Hep B and Hep C infection, and 2B is licensed to treat chronic hepatitis C virus infection. The adverse effects include a flu-like syndrome, and it tends to resolve upon continuous administration. This is flu-like syndrome जो होता है basically वो होता है immune body की immune reaction की वजह से होता है. And as आप जैसे progress करते हैं patient को वो करते हैं ये देते हैं, the immune system becomes used to it and it resolves upon its own. Potential adverse effects during chronic therapy include neurotoxicities, myelosuppression, profound fatigue, weight loss, rash, cough, myalgia, alopecia, tinnitus, reversible hearing loss, बहुत सारे हैं, retinopathy, pneumonitis, and possibly cardiotoxicity. So ये तो interferons हो गए, सही है. Moving on to contraindications, basically hepatic decompensation, autoimmune disease और cardiac arrhythmia की अगर history है तो आप नहीं देते इसको, and they are abortifacient in primates, so it should not be administered in pregnant women. Now moving on to the oral drugs, we have Edifovir dipivoxil. This is approved at lower and less toxic doses for the treatment of hepatitis B virus infection. It is a diacid prodrug of Edifovir, and it is phosphorylated by cellular kinases. And then it competitively inhibits the DNA polymerase of hepatitis B, and it causes chain termination. So basically, it inhibits the hepatitis B virus DNA polymerase. Oral bioavailability is unaffected by meals, and it is rapidly and completely hydrolyzed to the parent compound by intestinal and blood esterases. Protein binding is low, and the intracellular half-life is prolonged, ranging from 5 to 18 hours. Edifovir is excreted by renal mechanisms, which include glomerular filtration and active tubular secretion. So when a patient is having renal dysfunction, you have to monitor and adjust the doses. Potential adverse effects include headache, diarrhea, and abdominal pain. ये तो Edifovir हो गया. Now moving on to Entecavir. Entecavir is an orally administered nucleoside analog. It competitively inhibits all three functions of hepatitis B virus DNA polymerase, including base priming, reverse transcription, and synthesis of positive strand of hepatitis B virus DNA. Oral bioavailability approaches 100%, but is decreased by food. Entecavir should be taken on an empty stomach. Intracellular half-life of the active compound is 15 hours, so once daily dosing is possible. It is again excreted by the kidney, and dosage should be monitored and adjusted in the setting of renal insufficiency. So basically, जो वो थी Edifovir थी, it was inhibiting the DNA polymerase and causing chain termination. ये basically तीनों steps को वो करता है: base priming, reverse transcription of negative strand, and synthesis of positive strand. Both were being excreted by the renal, by the kidney, and dosage should be monitored in renal insufficiency. Potential adverse effects, again, headache, fatigue, dizziness, nausea, and upper abdominal pain, almost similar. Then moving on to Ribavirin, which is also a anti-HIV drug. It basically again inhibits DNA polymerase, resulting in chain termination. It results in rapid and potent virus suppression. Chronic therapy is limited by the emergence of Ribavirin-resistant HBV isolate. So इसको बहुत different तरीके से use करना पड़ता है. इसको use करके फिर stop करते हैं, फिर वापस start करते हैं क्योंकि resistant strains इसके आते हैं. Adverse effects are uncommon, but again they include headache, dizziness, insomnia, fatigue, dry mouth, and GI upset. Basically बहुत vague जो है ना इसके vague और वो similar symptoms हैं सबके. सही है? So Ribavirin हो गई. Moving on to the next one, it's Telbuvirin. It's a thymidine nucleoside analog with, again, its activity against hepatitis B virus DNA polymerase. It is phosphorylated by cellular kinases to the active form, which has an intracellular half-life of around 14 hours. The phosphorylated compound, which is the active compound, what it does is it inhibits the DNA polymerase competitively and resulting into incorporation into viral DNA and chain termination. Again, oral bioavailability is unaffected by food. Plasma protein binding is low, and serum half-life in सबकी approximately जो है ना 15 hours तक ही है. तो once daily dosing वाले drugs हैं ये, and the excretion is by renal mechanisms. Adverse effects again बिल्कुल vague और सबके सब तकरीबन similar ही हैं: fatigue, headache, cough, nausea, and diarrhea. Both uncomplicated myalgia and myopathy with elevated CK levels have been reported, as has peripheral neuropathy. Tenofovir is a nucleotide analog with activity against HIV and hepatitis B. Whereas tenofovir disproxil is a water-soluble prodrug of active tenofovir. Tenofovir disproxil is converted into tenofovir. And again, prolonged serum and intracellular half-lives allow once daily dosing. Again, elimination occurs by kidneys, and same mechanisms, glomerular filtration and active tubular secretion से होती है. Or renal insufficiency वाले patients में you have to adjust the doses. The most common, again, vague symptoms, वही symptoms हैं. Most common adverse effects of tenofovir in patients are nausea, abdominal pain, diarrhea, dizziness, and fatigue. Basically, most of the hepatitis B virus जो drugs हैं वो DNA polymerase को inhibit करती हैं. एक summary में ये हो जाता है कि जो है ना they are basically inhibiting the DNA polymerase, chain termination करवा रही हैं. हाफ लाइफ उनकी लंबी है, ओरल बायोअवेलेबिलिटी अच्छी है उनकी, वंस डेली डोजिंग की वो है इनकी कैपेसिटी है. एंड देन व्हाट यू कैन डू इज यू हैव टू मॉनिटर द पेशेंट्स क्योंकि ये उससे किडनी से एक्सक्रीट होती हैं बाय ग्लोमेरुलर फिल्ट्रेशन एंड tubular secretion. So what you have to do is you have to monitor the levels and adjust the doses in the patients with renal insufficiency. Now moving on to hepatitis C. Hepatitis C हम लोगों ने बात की थी कि जो hepatitis B virus जो होता है उसमें cure possible नहीं होता. What you have to do is you have to seroconvert the patient from you have to decrease the levels. So जो हमने बात की थी initially, तो cure is not possible in a lot of patients क्योंकि जो DNA virus होता है वो incorporate हो जाता है DNA में, host DNA में. Whereas when we talk about hepatitis C, it's a single strand positive sense RNA genome. इसका incubation क्या है 14 days to around 6 months, and transmission is most commonly by injection drug use. Then you also have blood transfusion and organ transplant से भी transmission होती थी before July 1992 जब screening और वो process बहुत अच्छा हो गया. उसके बाद से ये इसके इस blood transfusion और organ transplant के through इसकी transmission बहुत कम हो गई है. Vertical transmission occurs in mother to baby, and then you have transmission by needle sticks and intercourse as well. Again, it causes inflammation and fibrosis, leads to chronic hepatitis in 75 to 80% of the patients, whereas 20 to 30% progress to cirrhosis. इसमें again you have jaundice, spider angiomata, ascites, ecchymosis, caput medusae, ये सारे जो है end stage liver disease के वो हैं सारे, decompensated liver disease के signs and symptoms हैं ये सारे. And treatment, again, antiviral therapy, but the difference is that you can cure it. This is curative, and another difference is case mein you have there's no vaccine developed as yet for hepatitis C, whereas you have a vaccine for hepatitis B virus, जो preventive होती है. Okay, again इसमें एक और चीज़ है कि diagnosis is by hepatitis C RNA PCR करवाते हैं, anti-HCV antibody पहले करवाते हैं, and if it comes to be positive, then you move on to check the viral load by doing the RNA PCR. So moving on, इसके drugs थोड़े से जो है tricky हैं और थोड़े से hepatitis B virus के भी drugs बहुत नाम अजीब से थे, इसके भी ऐसे ही हैं. इसमें classification है which we have to look at. Make sure just have a go through to this slide क्योंकि इसमें तकरीबन सारी जो है ना इसकी जो basic जो pathogenesis है, overview है, features and diagnosis, laboratory findings. This is just in all of it is summarized into one slide. So just keep a picture of this one. It might help you in the short short जब आपको एक अचानक से summary या review करना हो तो it's a good slide. So treatment of hepatitis C, as we talked about, the primary goal of treatment in patients with HCV infection is viral eradication, as in contrast to Hep B. The rate of clearance in hepatitis B virus without therapy is estimated at 20 to 30%, 35%. So what happens is when a patient is infected with hepatitis C, तो उसमें ये होता है कि virus 20 to 35% of the patients में खुद ब खुद clear हो जाता है acute cases में. So when you go to a patient, a physician, तो वो क्या करते हैं, they delay the treatment for a minimum of 6 months. So ऐसा भी होता है कि patients अपने आप पे they recover. There are basically 4 classes of drugs which are defined by the mechanism of action and therapeutic target. Basically, what we have to look at is the proteins of basically hepatitis C का वो है, viral वो है, and it comprises of different glycoproteins, capsid, UcRNA polymerase, and these are non-structural proteins. Basically, the therapy for hepatitis C virus is usually inclined towards inhibiting these non-structural proteins. So basically, you have NS5A protease inhibitors, जिनके suffix है end होने में previr. The suffix is previr. Then you have the NS5A inhibitors, which end in SVir. And then you have the NS5B, which is the RNA polymerase, which basically end in buvir. So you have buvir, SVir, and previr. So basically, we have to look at these. Non-structural protein NS5A protease inhibitors. Then you have the NS5B nucleoside polymerase inhibitors. Then you have the NS5A inhibitors and NS5B non-nucleoside polymerase inhibitors. So the main targets of the drugs are the HCV encoded proteins that are vital to the replication of the virus. Basically, you inhibit either of these, it will cause the RNA polymerase. आप इनमें से किसी को भी inhibit करेंगे, they will eventually जो end result होगा वो protein formation आपकी रुकेगी इससे, and the virus will die. So moving on to the NS5A inhibitors, the ones which are ending in SVir. So what it does is it plays NS5A protein plays a role both in viral replication and assembly of hepatitis C virus. However, the exact mechanism of action is unclear. Daclitaxivir is used in combination with sofosbuvir for treatment of hepatitis C virus. It may be taken with or without food and does not require adjustment for renal or hepatic impairment. It is metabolized via the liver enzyme CYP3A and excreted primarily in the feces. Terminal elimination half-life is around 12 to 15 hours, and it is usually generally well tolerated. And most common adverse effects in patients receiving this combination is headache and fatigue, usually mild or moderate in severity. And if you use it with sofosbuvir and amiodarone, severe symptomatic bradycardia has also been reported. Elbasvir, again, S-Vir drug hai. So remember, it's a NS5A inhibitor, Elbasvir. It has in vitro activity against major HCV genotypes as well as some viral variants resistant to earlier NS5A inhibitors. It is only available as a fixed dose with Grazoprevir, and it is recommended for the treatment of HCV. Absorption is not food dependent. Peak concentration after ingestion occurs at the median of 3 hours. It is extensively bound to plasma proteins, partially eliminated by oxidative metabolism, and primarily excreted in the feces. This Elbasvir and Grazoprevir combination should not be administered to patients with moderate or severe hepatic impairment, क्योंकि ये उससे वो हो रही है hepatic इसका जो वो है metabolism है, it's hepatic. The most common reported side effects during therapy with Elbasvir and Grazoprevir combination were fatigue, headache, and nausea. Then moving on to Ladipasvir, and it is available in a fixed dose combination with again Sofosbuvir. It is not affected by इनकी आप notice करेंगे कि इनकी जो pharmacokinetics और dynamics हैं usually जो ना similar होती हैं, बहुत ज़्यादा vary नहीं करती हैं. So not affected by food intake. Median peak plasma concentration occurs 4 to 4.5 hours after oral administration. Highly bound to plasma proteins, and unchanged drug is the major species present in the feces. No adjustment is required in the settings of mild or moderate renal insufficiency or mild, moderate, severe hepatic insufficiency. Again, fatigue, headache is the most common adverse reaction. And again, Sofosbuvir or Imudron के साथ अगर आप इस drug को use कर रहे हो तो severe symptomatic bradycardia has been reported. Again, one more drug, Ombitasvir. It is only available as a fixed dose combination with Palitabravir and Zetonavir for the treatment. Peak concentrations are reached 5 hours post ingestion and highly protein bound. Route of metabolism is via biliary excretion. And this combination is contraindicated in patients with moderate or severe hepatic impairment. Most commonly reported adverse reactions are nausea, pruritus, and insomnia. Pruritus or nausea वगैरह है ये basically biliary upset की वजह से होता है. And increased serum aminotransferases have also been reported. Well, Palatasvir, it is available is only in a fixed dose combination with Sofosbuvir. First, only daily drug tablet regimen with pan-genotypic activity. Okay. No dose adjustment is required for patients with mild or moderate renal insufficiency or any degree of hepatic impairment. It is metabolized by the CYP class of liver enzymes, and peak plasma concentration is observed at 3 hours post-dose. Headache and fatigue again is the most common adverse reaction reported by the patients. Now moving on to the NS5B drugs. ये सारे जो drugs हैं, हमने बात की थी NS5B वाले, these are the Buvir drugs, and they inhibit the RNA polymerase. इसमें आपके पास nucleoside inhibitor है and non-nucleosides हैं. So NS5B is an RNA-dependent RNA polymerase. As we talked about, NS5B is an RNA-dependent RNA polymerase involved in the post-translational processing that is necessary for the application of hepatitis C virus. The enzyme's structure is highly conserved across all HCV genotypes, giving agents that inhibit NF5 this drug efficacy against all 6 genotypes. Basically, हमने बात की there's non-nucleoside analogs such as Dazabuvir, and we have the nucleoside analogs such as Sofosbuvir. Dazabuvir is a non-nucleoside inhibitor available only as a fixed dose combination with Ombitasvir, Palitabravir, and Ritonavir for the treatment of hepatitis C virus. Available absolute availability is 70%. Peak plasma concentrations are reached 4 hours post ingestion, and primary route of metabolism is via the CYP class of CYP3A and CYP2C8. Again, most common reported adverse reactions were nausea, pruritus, insomnia. Increased aminotransferase levels have also been reported, particularly in women using the ethinyl estradiol OCPs. Sofosbuvir is a nucleotide analog, and it is administered in combination with several other anti-HCV medications, including Daclataxavir, Simipravir, pegylated interferon alpha, plus Ribavirin or Ribavirin alone. It's a prodrug that is rapidly converted after ingestion, which is efficiently taken up by hepatocytes and converted by kinases towards pharmacologically active uridine analog. It is administered without regard to food, and peak plasma concentrations are observed at 0.5 to 1 hours post-dosage. It is metabolized in the liver, and renal clearance is a major elimination pathway. And no dose adjustment is required for patients with mild or moderate renal insufficiency or any degree of hepatic impairment. It is generally well tolerated, and the drug adverse effects are difficult to discern since it's always administered with other antiviral agents. Now moving on to the NS3A, NS3 and NS4A protease inhibitors. These are the drugs, जिसका जो suffix है, which ends in previr. So they are the inhibitors of NS3A, NS3 and 4A serine protease, and it's an enzyme involved in the post-translational processing and replication of hepatitis C virus. All of these end in the suffix previr. It's a potent protease inhibitor, reversibly binding to the protease, and it is only available in combination with elbasavir for the treatment of hepatitis C. It can be taken without regard to food, and concentration of the plasma are reached at a median of 2 hours after ingestion. It is extensively bound to plasma proteins and distributes predominantly in the liver. Eliminated by the oxidative metabolism, primarily by the CYP3A class, and is mostly eliminated by in the feces. Again, side effects: fatigue, headache, and nausea, and elevation in serum aminotransferases may occur. Favipiravir is only available as a fixed dose combination with ombetacivir and ritonavir for the treatment of hepatitis C. Absolute bioavailability is 53%, which is not for you to remember. Peak plasma concentration are reached 4 to 5 hours post ingestion, and is extensively protein bound, and primarily its metabolism route is CYP3A4 class. Adverse effects, again, nausea, pruritus, and insomnia. Increased serum aminotransferases have also been reported, again in women, using the ethinyl estradiol containing contraceptives. Semipravir is used in combination with sofosbuvir, with or without ribavirin, for the treatment of hepatitis C virus, and it may also be used in combination with interferon alpha and ribavirin. It must be taken with food to maximize the absorption. Concentrations of the plasma reached in 4 to 6 hours post ingestion, and extensively bound to the plasma proteins and metabolized by the liver, in the liver by CYP3 class. It also undergoes biliary excretion. Semipravir is not recommended in patients with moderate or severe hepatic impairment because of 2 to 5-fold increases in exposure. It is generally well tolerated, and photosensitivity and rash has been reported occasionally. Severe pruritus and nausea may also occur. Transient elevation in bilirubin may also occur with semipravir. Since semipravir contains it's a sulfur drug, so it should be used cautiously in patients who have prior history of sulfur drugs, allergy to sulfur drugs. Now, ribavirin is the last drug which is used to treat hepatitis C. It's a guanosine analog that is phosphorylated intracellularly by host enzymes. Although its mechanism of action has not been fully elucidated, it appears to interfere with the synthesis of GTP and to inhibit the capping of viral messenger RNA, and to inhibit the viral RNA-dependent RNA polymerase of certain viruses. So basically, क्या करता है? It interferes with the synthesis of GTP. It inhibits the capping of viral messenger RNA, जो basically important होता है उसका आगे RNA जो viral RNA formation में, and to inhibit the viral RNA-dependent polymerases of certain viruses. So the absolute bioavailability of ribavirin is 45 to 64%. Again, not important percentage याद रखना. Increases with high-fat meals and decreases with co-administration of antacids. Plasma protein binding is negligible, and it is primarily excreted to the urine. Therefore, clearance is decreased in patients with decreased creatinine clearances. So again, ये drugs हैं, इनकी वो हैं जो properties हैं वो usually similar हैं, almost similar होती हैं, थोड़े differences हैं. The thing is, you have to remember the names, you have to remember the mutual जो इनकी वो हैं kinetics और dynamics हैं, pharmacokinetics, pharmacodynamics, ये सारी आपको याद वो करनी है. Percentages वगैरह इतनी important नहीं होती हैं. Usually they ask for the names of the drugs, and sometimes they ask pharmacokinetics and dynamics, and usually जो क्लासिफिकेशन होती है जैसे NS3 protease inhibitors, NS5A inhibitors and NS5B polymerase inhibitors वगैरह, ये इस तरीके से, and the mechanism of action of these drugs and the mechanism of action of interferons वगैरह, this is what's important. Percentages or eliminations और ये सारी चीजें they don't usually ask. So I think this is it. And any questions, happy to help.
Oh yeah.
Yes. Any questions?
जी सर.
देख